All
right. Hi, everyone. Welcome to the 27th session of virtual shadowing. Today, we have a PA spotlight in gastroenterology with Peter Trin, a physician assistant. Feel free to reach out to us at Instagram at virtual shadowing or email us at virtualshadowing@gmail.com. Our sessions will be recorded and posted to our YouTube channel, which is Pre-Health Virtual Shadowing. Next slide, please. Here are our upcoming sessions. So next week, we have Path to Being a Nurse with Kyle Martin, a nurse practitioner. The week after that, we have a specialty spotlight in PM&R with Leah. And on December 22nd, we have Burnout in Medicine with Dr. Courtney. Join us on Zoom or YouTube Live at 7 p.m. Central Standard Time for these sessions. Next slide, please. Here's the virtual shadowing working group comprised of Reagan, Cheyenne, Taylor, Rachel, Ani, Miriam, and myself, as well as our three physicians, Dr. Fowler, Dr. Marchetti, and Dr. Salazar. And Dr. Salazar had a quick thing to say about his program.
Hey guys, good evening. Hope everybody's doing really well. I'm gonna announce tomorrow a big giveaway. I'm gonna be giving out an opportunity to attend the very first episode, the live pilot of our first virtual clinical observation program. So look on my Instagram tomorrow morning. That's gonna be G Salazar _ TX2020, G Salazar _ TX2020. We'll be giving away some scholarships to attend the program. We'll be giving away some Christmas presents mailed to you and some meet and greets, virtual coffee with some of the faculty. So check on my Instagram page tomorrow for the big announcement. Look forward to seeing you. Good luck.
Next slide.
Yeah.
Okay. Oops.
We'll have two Q&A sessions. One will be in the middle and one will be at the very end of the presentation. If you have any questions, please put them in the chat as we go along. If you have any questions about the quiz, hold them till the very end. After the session, we'll give you the question for the quiz. And with all that said, please welcome Peter Trin.
All right, so let's get started on the session. I first want to thank the virtual shadowing group, this Brady Bunch family, for reaching out to me and allowing me to participate. And so I hope this will be a fun but yet informative session for all of you all. And so, yes, I practice in gastroenterology, and I practice as an advanced practice provider, a PA, physician assistant. And in today's outline, I kind of wanted to cover a little bit of everything, a brief introduction about myself, the pre-PA route, what PA school is kind of like, and then transitioning from that new grad period into working as a PA, and then some diseases, procedures that are done in the world of gastroenterology, and what I specifically do as a PA. And then I hope to go over two quick case studies and then some last tips and pearls, and then Q&As and stuff like that. So let's get started. So quickly about myself, I'm from the great city of Dallas, Texas, born and raised here all my life. And I went to undergrad at UT Dallas. I got my degree in healthcare studies. And with that in mind, I intended to pursue PA school. And so I went to my dream program of choice, actually UT Southwestern in the heart of Dallas. And couldn't have been more thrilled. It's a great, phenomenal program. And, you know, I just rave about it. Absolutely love the program. And I now practice in gastroenterology. That was my first pick. So I'm very happy with where I am at right now, starting out in my career in medicine. And then, you know, I always feel like it's great to include what you are outside of medicine because I'm not just my job. I love being outdoors and hiking and camping and stuff like that. I love nature. I feel like it's a really good reset, you know, a great way to break off from like technology and all that stuff, Instagram, you know how it is. And I like to stay fit. I'm a coffee addict and yeah, I like to eat and I like reading about finance stuff. I'm a little bit of a nerd with that. I also realized these lights might close, so I might have to say things like, Alexa, open these lights and stuff. So I apologize in advance for that. Okay, so I just wanted to start off the slide with this little picture right here as far as what PAs can do and open it up in that way. If you kind of take a look at this diagram, as far as what PAs can do, being involved in surgeries and procedures, ordering tests and diagnostic tests, coming up with treatment plans, you would almost think like, between PAs and our MD colleagues, DO colleagues, our doctor colleagues, it's kind of great. And so that's, we can do a lot of, as far as our license and our scope of what we can do a lot of what our doctor colleagues can do. And by that, we are what I feel like a good extension. That's how I always pitch myself. I feel like I'm a good extension of the 5 providers that I work with. And so it's almost as they're more far reaching as what their abilities and what they can do for their patients. So, whenever you're thinking about PAs, I hope the word collaboration comes to mind, because that's how I feel my role is in the team. And so that's why I love what I do. And so with that said, as far as the pre-PA route, I actually switched from the med school route, wanting to be a doctor, to finding out that the PA route was a better fit for me. And so I went in it beginning my junior year. So, freshman and sophomore year, I thought I was going to be a doctor. I had the full intent, but I did a little bit more of my research and everything. And I felt that the PA route was just well suited for me, better for me. So with that said, the PA route, it's very similar to what the pre-med route would be. Lots of volunteering. I did a lot of my volunteering at Medical City of Dallas at the front desk and through the healthcare clubs at UT Dallas. And then I like volunteering too. So, some of the random 5Ks I would do. And I remember I was on Ninja Warrior. They were at Fair Park. They're actually hosting an episode there, and they just needed people to volunteer and being part of the crowd. So that was kind of cool. And then moving on, shadowing PAs, that's really important too. So I feel like, it's good to shadow PAs to really get an idea of what they do, the ins and outs, the logistics, getting their overall impression, like, what were their experience like when they were pre-PA? Are they satisfied with their job? If they could go back, would they do it all over again? Things like that. So I feel like shadowing different PAs, it's very paramount to really find out if this position, if this role really is for you. And with that said, even, shadowing doctors and stuff too, to see if maybe that's a better fit for you, if that's what you want to do instead. So I had about 50-ish hours total of shadowing. So not too much, but in the grand scheme of things, I did start a little late. And then PA school they really harp on patient care hours and experience. So what that means is a lot of hands-on experience in practice. So a lot of what I did, I think I was kind of being a little sneaky there, being a farm tech and a physical therapy technician. I won't lie. But in hindsight, I feel like if you were an EMT or a medical assistant, a scribe or something, you'd probably get more value, and that can carry over into PA school. I'm sure the scribes and the ED departments have just a whole host of stories that they can share, and those experiences that would be, fruitful once they're in school and things like that. But having a lot of real world hands-on experience is very, 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 very paramount when entering into PA school. And I know that can be a little difficult, as you're an undergrad and you're doing this and that volunteering, and you have to find time to lay hands on the patients and do something for them. But it's something that they look highly towards. And so the reason I chose medicine and in general is because it was always in me to help others. That's very generic to say, but I mean, it's true. And so I feel like that intrinsic value with what I'm interested in and what I'm good at, science and medicine, it just kind of came together, wrapped up beautifully. And so I thought medicine was something that I can thrive in. And so, more so with being a PA, first I wanted to mention the hierarchy of things. So, I do realize, I mean, it's in the title, physician assistant. And so you're not technically, the head honcho and things like that. You have an overseeing supervising physician. And so, but for me, technically, my focus was on the medicine, was on the patient care and their health and their outcomes. So having the whole hierarchy really didn't bother me at all. We know in PA school that there is a substantial less of a debt burden overall, right? So, and then Texas is actually a perfect place for PA students in general, because I just roughly speaking, if you're looking across the board, there are multiple schools in Texas that cost, and I'm talking about the whole program in total, roughly about $40,000. So, I mean, that's really not a bad gig. That's just tuition I'm speaking about. So, I mean, if you're comparing that tuition to how much a PA would make coming out, I generally use the number of 100,000, 6 figures. So that debt to income ratio is really not that bad. I mean, it's less than 1 already to begin with. So that can be enticing too. Duration of school is also less too. My program specifically was about 30 months. And I would say that's about average compared to, 4 years of med school and then your residency, depending on what specialty or, what field you want to go into, like medicine, 3 years. And then if you want to do a fellowship after that, so it's a shorter duration of school. And then another cool thing about PAs is that we can lateralize. So what that means is you're not pigeonholed into one specialty, into one role. So I have met a PA actually. She was like an adjunct professor or whatever. She went into neurosurgery and she found out she didn't like that. So then she went to cardiology. She found out she didn't like that. And then now she's doing hospital medicine. So, you know, we really can get in where we fit in, so there's no, just because you pick this one specialty, you're not locked into it for the rest of your life. In the grand scheme of things, you don't find PAs hopping to different specialties just on a whim, just because we just feel like it. There is some caveats to that, but the option is always there for you. And then I find that there's excellent work-life balance with being a PA. A lot of people will say, it's the family that they are mindful of whenever, they're choosing this career. And so they feel like they can have the satisfying role, this job, but still have plenty of time to spend with their, quality time to spend with their family, which I think is beautiful. And we take the GRE as of right now overall, instead of some kind of, MCAT. There is a PA CAT now, but that hasn't taken full blown effect yet. So essentially we're taking the SAT on steroids in order to get into PA school. And so, yeah, my advice, like I said earlier, was shadow both doctors and PAs, when you're in your early years, just gain as much experience and insight as possible. So go seek out both of them, and try to get their insight and wisdom and all. So PA school, again, I went to UT Southwestern in Dallas. And so it's pretty well known, I would say. Tuition is pretty cheap compared to other schools, I'll say. And then we do the multiple mini interview session at UT Dallas. So it's nothing that you can prepare for. You're at stations and there's different prompts that you do. Okay. And so it's actually a lot of fun interviewing like this, I think, but it really helps UT Southwestern to stand out in that sense. And then cool thing about my program specifically is they also will pre-assign and arrange the rotations for you. So whenever you're doing your clinicals, you can just focus on the school and everything. You don't have to focus on, finding preceptors like, hey, hey, Dr. Fowler, can I shadow you? Will you accept students right now? And then you got to worry about housing and everything. Like that's all taken care of for you. So that's really cool. And again, my program is about 30 months long, so I feel like that's average. And my elective rotation, I did in gastroenterology because I felt like that's something I wanted to go into. And then I did pediatric ER because I thought I wanted to work with little babies and kids and stuff, but they actually frightened me. So it's not my forte, but which is good because I found that out, right? Doing the rotation. Um, oh yeah, so I also mentioned I put the rank of UT Southwestern not to gloat or anything like that, but I wanted to provide insight as far as it really doesn't matter what program you go to, what rank they are. At the end of the day, you go to an accredited school, you do well, you graduate, you pass the national boards, and you're good. Your employers, whenever you're trying to find your big boy, big girl job, they care about the experience. They care about you as a person. My ranking and going to UT Southwestern, as prestigious as that was, it really didn't carry far as me finding a job or anything like that, really, truly. So I just wanted to make that a point for everyone. And then PA school training, we mirror the curriculum of med school, which is what you want too, because whenever we're practicing medicine, like I said, we're like an extension of the doctors. So, I mean, we want to think like the doctors do. We want to have that medical model background. We want to, develop that ability to create this differential, filter it down with our chosen diagnostics, come up with a treatment plan, and so on and so forth. So our basic science courses that the med students would take too, anatomy, physiology, neuroscience, things like that. And then cadaver lab. So UT Southwestern is also very fortunate to have the PA students along with physical therapy students and stuff actually dissect. We're not prosecting and looking at stuff that's already been teased out and everything. We're going in there ourselves and we're exploring the wonders of the human anatomy. So that's pretty cool. And then our clinical blocks are, cardiology, OB-GYN, nephrology, kidneys, GI stuff. So we go through basically like all the systems and things like that. And then when you're on your clinical rotations and out there learning in the real world with the help of a preceptor, in this picture, I listed the rotations that you would do as far as at UT Southwestern, but generally they're all about the same. And you can see like 8 weeks is usually like family medicine, internal medicine. So UT Southwestern tries to train you with the primary care focus, right? A little bit of everything. And then your preceptors, they're going to be, so I was with doctors, I was with other PAs, I was at NP. So you kind of get a little bit of everyone in the mix. So, which is what I like. And so clinical rotations, 15, so it's half and half usually it's how they're structured. So by and large, it's about 15 months of real world practice. So, okay, yeah. So that's kind of like the gist of PA school and all. And then as a new grad, so I did all of that. And then as a new grad, I graduated December of 2018. And so, like I said, I knew I wanted to be in gastroenterology. I knew this was a field that I can thrive in. And so I sought that position and I was lucky enough to get it. And then, my experiences as a new grad, I'd say it's very similar to your intern year, right? As far as when a med student graduates and then they start their first year of residency. So, even though I was graduated, I have this diploma and everything like that, I very much felt like a student still. So there was tons and tons to learn, especially when you're, in a specialty focus too. Like you're the GI specialist right there. People are asking you for, recommendations and things like that. So just so much more to learn. It's a steep learning curve whenever you're coming fresh out of school and you're, that freshman and everything. And but the 4-week elective rotation was very helpful. So I always tell people, I mean, at least one of your elective rotations should be something that you think you might be interested in. So As far as I think GI is just, it's fascinating. I mean, there's so much breadth and depth to it. I mean, what we treat, spans the mouth all the way to the anus, the whole alimentary canal. So I mean, it's pretty long, right? So, and then it's a procedure focused field, even though PAs and NPs really we have a very limited role in procedures, but it is a procedure focused specialty. And then from what we see, we can see the stable patients all the way to sick patients and the emergent cases too. You can have that cirrhotic bleeder in the ER, the GI bleeder, okay, the severely acute pancreatitis patient. So we can see just a whole spectrum of what a patient can present with. It's very beautiful, and then it makes sense to me. So what I tell students is, as far as when you're picking your specialty, where you think you belong, just triple down on whatever you think you're good at, like I don't know, to me that just makes a lot of sense. So if something clicks with you, then I feel like, it vibes with you. So that's something that you might want to pursue. Okay, so gastroenterology, a little bit more about that. So we specialize in digestive issues. So again, that's the whole GI tract is pretty long, right? Everything you see there in orange is basically what we own up to, what we treat. So from esophagus to anus down here. And then so our tools are our scopes. It's those long tubular cameras and things like that. So our scopes comprise of an upper endoscopy or an EGD. If you want to look at the small bowel, so the EGD is the upper GI tract. If you want to look at the small bowel, you'd probably want to do a deep enteroscopy or a double balloon enteroscopy. Colonoscopy is looking at the lower GI tract, from rectum all the way to the end of the colon, or the terminal, or the cecum and terminal ileum, if you will, too. And then endoscopic ultrasound, that's like an EGD with an ultrasound probe at the end. So, I mean, that's pretty cool too. And then an ercp. So I'll kind of have like pictures later at the end to kind of guide you as far as the region of where we're exploring. So a little bit more about that later, but yeah, so a big reason as to why you might want to get in touch with your gastroenterology team and colleagues is because we have access to the scopes, and so we can better characterize and rule out, cancer and malignancy and other things like that with our tools, with our scopes. And so, the specialty also grants you, subspecialization. So there's some doctors and or people that are so focused on one thing in GI, like esophageal disorders, motility to be specific, like how your esophagus is functioning and moving or not moving, how the esophageal sphincter is behaving, and how that's affecting your difficulty with swallowing and things like that. Hepatology is a whole field in itself. The liver transplant, really transplant heavy is what they are specialized in too, but complicated cases of hepatitis and things like that. Biliary pancreatic specialists too, inflammatory bowel disease, and functional stuff too, like irritable bowel disease. So you can really get really finite into GI if you wanted to, or you can stay pretty broad. So that's what I mean by the breadth and depth of this specialty is really enticing to me. And then, so common referrals / consults, as far as, again, why you might want to reach out to your GI colleagues. Refractory GERD, meaning, acid reflux. That's pretty easy to treat. I mean, we can all learn that in a medical textbook in like, an hour or so, but, sometimes there's a little bit more exploring we got to do to rule out other, dangerous causes and things like that. Dysphagia is difficulty swallowing. So that's something typically that, I see a lot too. And so we might want to explore with, as you might think, like an upper endoscopy, right? To check out the upper GI tract. Nausea, vomiting, dyspepsia is your classic, I have indigestion issues. Elevated liver enzymes, that's classic. We get that all the time to work up. Cirrhotic patients too. So those that have this really scarred up, bumpy, lumpy liver. Liver masses, pancreas masses, that are found incidentally, so by accident on imaging when you were looking for something else. Pancreatitis, finding out the cause for that, just general abdominal pain whenever uh, maybe a primary care provider can't figure out exactly why, and they might want to reach out to their GI colleagues again for scopes and further assessment. Bowel changes, so a lot of constipation, a lot of diarrhea. So poop is something that we just get comfortable with, like poop is nothing to me, right? So, we're talking about poop, doing a rectal exam, boom, we're going to lunch. Like it's not a big deal. We're just so comfortable with it. And then GI bleeds that's a big one too. So hematemesis is whenever you're throwing up and you see blood. So you're throwing up blood. Hematochezia is whenever you have rectal bleeding and signs of that. And melena is whenever you're having black stools, tarry, like street tar consistency. Usually it's like really foul smelling too. And so that's another big thing that we try to explore as well. If you're bleeding somewhere along the long GI tract. And then iron deficiency anemia, we get consulted for that very regularly too. And so whenever someone is iron deficient, you're really, what ticks you off, your spidey senses and all, is like cancer, like cancer until proven otherwise. So let's further explore. So those are all common reasons why, again, you might want to reach out to your GI colleagues. And then there's so many diseases, I can't even list it all, but some more narrow focused diseases as far as like the upper GI tract that we treat are peptic ulcer disease. So if you have ulcers in the stomach or the small bowel, the duodenum, generally more than likely these are due to NSAIDs like ibuprofen, Motrin, Advil, Aleve, Naproxen, and even BC powder. People take that for headaches too, or the H. pylori bacteria infection, which is what the diagram is displaying. So this is a very nasty bug that can thrive in the acidic environment of your stomach and cause problems that later on down the road, like in your life down the road. And so you can have, dyspepsia, so indigestion. You can have bleeding from it. You can have iron malabsorption, and so now you're iron deficient. This can later on lead to cancer, like a lymphoma. So that's something we're pretty aggressive towards treating. Esophageal dysmotility. So that's like whenever your esophagus just is a catch-all term for it's not moving correctly, right? So, if you really read into like how your esophagus functions, it is actually how your whole body functions too, right? It's just a coordinated symphony. And so whenever it's not moving correctly, yeah, you're going to have difficulty swallowing, refractory GERD. You're going to have some vomiting episodes and things like that, chest pain. And so that can get murky because you're having this patient that's presenting to the ER. And so, of course, they're going to get the workup for cardiac issues because that's going to take you. But, sometimes that can muddy the waters a little bit. Gastroparesis. So that's whenever your stomach is like slowing down. So, your stomach is not propelling food forward towards the small bowel like it should be. Generally speaking, that's somebody that has a long history of diabetes. Okay, but it can be somebody that is taking a lot of medications like narcotics and anticholinergic medications. Somebody that's had surgery around the stomach and things like that. So gastroparesis, stomach moving all funky and stuff. Gastroenteritis, I threw that in there, but I guess since you're having lower GI symptoms, you can consider it kind of lower GI. But that's just, we use that term for, you got this like stomach flu, you got like the stomach bug. People are usually referring to some kind of gastroenteritis, whether that be viral or whatnot, bacterial. Celiac disease too. So that's going to affect your, your small bowel and everything. Gluten intolerance and everything, where, it can cause bloating, abdominal pain, iron malabsorption. It can cause diarrhea, consequently can cause constipation too. So those are some of the things we treat. Moving down towards the lower GI tract, okay, we're treating things like inflammatory bowel disease. So that's huge, right? That's ulcerative colitis or Crohn's disease to super autoimmune type diseases that can, that's a whole spectrum in itself too. You can have the really stable patients to those that are just like refractory to all this management. They're in the hospital, they're sick. And so they might require surgery and extensive removal of their bowels and just reconstructing the whole anatomy. Like it's wild just how varied it can be. Other conditions include microscopic colitis, and that's something that you know, you have to diagnose with pathology. So if you look at the colon with the naked eye, it's going to look okay. But then when we take a random biopsy of it just to rule out this disease, you're going to find inflammatory cells attacking the colon, and that can be causing a lot of diarrhea, like 12 episodes a day kind of diarrhea. Ischemic colitis, whenever you're having reduced blood flow to the colon, that can cause diarrhea, that can cause bloody diarrhea, can cause some abdominal pain after eating and such like that. C. diff colitis is big. C. diff is on the rise. There's more instances of community-acquired C. diff now. So C. diff is something, if you run across a medical textbook, it's classically going to be after somebody that has taken an antibiotic. And so you kind of disrupt the normal flora in your colon. And so now the C. diff is like, oh, hey, you know, this is a perfect time for me to thrive and do things. So it's going to proliferate and cause a lot of diarrhea, some bloody bowel movements too. And so it's something I quite commonly treat as well. Hemorrhoids too. So that's, you know, blood pooling into your rectum, and it's basically not going back into circulation. So now you have this little bulging vessel essentially that's prone to bleed. And so that's something that we commonly treat as well. And then some other diseases, GI bleeds, esophageal varices, peptic ulcers, diverticulate. So GI bleeds are something that we commonly get referred to about. And so esophageal varices, now those are the scary things, right? So I'm sure my ER colleagues can attest to that. Whenever, you know, there's a GI bleeder and they're coming in with hematemesis, and you're asking about their alcohol history, or if they had history of cirrhosis, I mean, your anal sphincter gets a little bit tight, right? So those are the scary patients, because I myself have experiences with seeing how the bleed goes, but I hear it can be profuse like a hose. And so yeah. So I'm glad I've never seen it, and I don't want to, but those things, when they pop, so they're gonna sit in your lower esophageal region most likely, and that mucous membrane over there it's very thin. So whenever whenever those things pop, I mean, you know, we got to scope them as soon as possible, as much as you know, we have like 12 hours to essentially scope them after, you know, they're stabilized and everything like that. So those are the scary ones. Other diseases like liver diseases, non-alcoholic fatty liver diseases, and it is NAFLD, that acronym NAFLD. And so that's classically like somebody with metabolic risk factors. And what I mean by that is somebody with hypertension, obesity, cholesterol problems, hypertension, so blood pressure issues. So I normally refer to that, and I don't know if I coined this term, but if no one's used it, then I coined it. But the American triad, you know, cholesterol, hypertension, and diabetes problem. And other things, alcohol, hepatitis. I think I messed up on that acronym. It should be ETOH. But so alcohol or liver disease because of alcohol use, viral hepatitis. So like viral hepatitis A, B, C, D, E, if you will, too. And then cirrhosis, which is basically what this liver is looking like up here. It's very lumpy and bumpy. And so that requires tons of management. Once that liver gets like that, you know, a whole host of things can go wrong if you don't properly manage them. And that includes esophageal variceal bleed, pooling of fluid into the abdomen to where, I mean, they're looking like they got twins up in the belly. Like it's gnarly. Really severe swelling in the feet. They can have mind-altering symptoms and confusion, and that can lead to a coma, and that can lead to death. So there's a whole lot that can go wrong with the cirrhotic. And then we're also treating biliary pancreas disease, so PBC, PSC. Those are essentially diseases of the bile duct, you know, common bile duct, the intrahepatic ducts, things like that. Choledocholithiasis is going to be, if you've seen the diagram, the common bile duct labeled, that's going to be where the stone is. Whereas, you know, you can have stones in the gallbladder too. And cholangitis is an infection of the common bile duct. And so yeah, I mean, that's already like so much right there. And then irritable bowel syndrome, things of that spectrum, like functional GI diseases, those can be a little bit tricky because what I mean by functional is we're doing all of this workup. We're doing the $1 million workup with scopes and labs and imaging, and we just cannot find a cause, a true organic cause to like treat. So we're just managing symptoms. So it can get really frustrating and as a provider, because you want to help people, you want to cure them, but I mean, this is not something that you cure. And so patients are, it's hard for them to accept that something functionally is wrong because they want to find something that's wrong so that you can fix it. So that's just a little bit between the upper, lower, and all the other diseases that we commonly come across in GI.
Okay, so we have a couple for you. A lot of people had some questions about PA school specifically. One of them is, what was the hardest part of PA school for you?
I would say the hardest part was not just, but like learning all of that material in a condensed manner. So, going 15 months straight into didactic, meaning classroom traditional training with the lectures and everything, much like this. And then 15 months out, we're doing, I mean, they say it's like the medical school curriculum, just kind of more jam packed and stuff. So it was just more denser. I mean, it's definitely doable. I think anyone can do it, but it's definitely just dense to me.
How was an average day for you in PA school? Like, were you able, like, do you have a nice work-life balance there? Can you talk a little bit more about that?
Yeah, absolutely. So if you ask me compared to other people, I think PA school is doable just amongst anything else. Just you have to prioritize things. So yeah, traditionally or normally we'd be in the classroom from like 8 to 4 or 5 o'clock, but after that, I would still find time to work out, still find time to study and cook dinner and things like that. I don't think PA school or school in general, med school for that matter too, should deprive you of your time with your family, with your friends, and you time. I think if that's the case, then we need to work on some time management skills and reprioritize things. But some people are a little bit dramatic about, PA school and things like that. And I don't think that's the case. I think you could still thrive and have a good life while studying in PA school and things.
Okay. Have you ever known any, so there are like cases of like people going to medical school and then deciding to go to PA. Have you ever known of anyone who went to PA school and then decided to go into medicine instead?
Yeah. So I definitely think it's a two-way street. I've known some people in med school that, realized that wasn't for them, or maybe life happened. And so, they had to drop out. Instead of reapplying, they went to PA school. Consequently, to be honest, I know some colleagues that do a lot of ranting, and they wish they went to PA school. So some reasons would be the hierarchy of things, and they just don't want that supervision. So they want all of this autonomy and things like that. So which is fine. At the end of the day, it's your personality and it's what's a good fit for you. But that's why I always say shadow these people and really tease. Like when you're shadowing them, don't. I mean, it's cool to learn about the medicine and science and all that, but I mean, you also have Google for that. So whenever you have that one-on-one time, I really push for those questions that are really meaningful. Like the wisdom and the insight you can gain from it. So.
Okay. Have there been any intense moments in your job so far that like you've actually seen?
Intense, is that open to my interpretation of intense?
Sure.
Okay, I guess I can answer in one instance where intense meaning, so whenever I started my position, especially in the hospital and rounding and things like that, I was by myself, so I was rounding and seeing these patients. So sometimes, I mean, my ER colleagues can attest to. I mean, sometimes it can come in waves. You're just hanging out, having coffee, and then all of a sudden, 3, 4 consults start to come in, and they could be like sick people to like, they're going to ICU soon. You can see them up there. And so sometimes that can get overwhelming and intense, especially as a new grad, and you're still just trying to learn the ropes and everything like that. So, as a new grad, it was daunting to see these patients and everything, not have my physicians with me. But over time, you get used to it. I'm still rounding, and discussing with the attendings at the end of the day. And then intense as far as like patient care intense. Yeah, I remember one time I was taking care of a patient with alcohol hepatitis. She was coming in, supportive care. We're trending her LFTs, her INR, giving her fluids and whatnot, just watching her, right? And then she leaves home against so she leaves AMA against medical advice to go take care of her cat. When we tell her no, I don't think that's a good idea. She starts drinking more whenever she's at home. So she comes back. She comes back to the same ER, same thing. I see her for one day. And then, she's down in the ICU now, and she's on a rotoprone bed, and she's like folded up like a burrito. And I can't even see her face. I don't even know what I'm looking at, to be honest, my first time. And then a few days later, she's dead. And so I'm like, that's wild. That's strictly from alcohol too. She probably got, her immune system is compromised and everything like that. So she probably got pneumonia, she got septic, and then just everything spiraled downhill. So I thought that was pretty wild right there, to have that clinical course like that. So.
Okay, that was interesting. I'll just ask one more question before we move on.
All right.
What's your advice to pay tuition and expenses for PA school?
What was paying for that?
Yeah.
So I wish someone would tell me, but so scholarships, of course, right? But just mass apply. And so I tell my students that, that I mentor, that follow me, like, you want to apply to areas where the applicant pool is smaller. Like there's the Coca-Cola scholarship, there's the Thailand scholarship. Those are all cool. And, there's a lot of money there to be won. But you're probably not going to win with the amount of applicants coming in. So, whereas if you reach out to your local hospital, like here in Dallas, if you reach out to Medical City Dallas, you reach out to, other smaller organizations in your area, I feel like the applicant pool is a lot smaller. And so when you apply to it, apply with the same, like almost the same template, the personal statement that you're using. It's all about volume, right? So you're applying to 100, you're getting about 1 or 2. That's great. That money is free. It's tax free. So, you're not paying taxes on it, which is good, right? Because you're saving yourself potentially like 22, 25% on the tax rate on that money. And you don't even have to pay it back. And once you put up the upfront work and you have that personal statement, that template, you use that to mass apply, and you just change some things and tweak that here and there. And then you have at least three people you can reach out to on deck that can write you that can send you a letter of recommendation, meaning they already have their template too. So all they're doing is just sending the same letter and just crossing out the organization they're sending it to. And so it's all about volume, and it's all about mass applying and working smarter in that sense, right? So it'd be cool to go to med school on a full ride or PA school on a full ride, but at the end of the day, if you just racked up a few $1,000s, in the grand scheme of things, that saves you a ton of money. So that would be my advice.
Thanks for the advice. Let's move on for now.
All right. Thanks for the questions. Okay, so more focused now on my duties as a PA. So I want to introduce you all to my I don't know why I'm losing my mind, supervising physicians that I work with. So I work between 5, and so it'll vary between PAs. Some PAs work solely with one provider, and some work with, like me, up to 5, and some work with more. But so I work with these 5, Dr. Evans, Dr. Fajardo, Dr. Matthews, Dr. Pucha, and Dr. Rendon. And then there's another PA. So there's 2 PAs total, including myself. And so what I do is, I'm out there in the community. So I work half inpatient and half outpatient. So half outpatient is a clinic full day. And so I'll see up to 16 patients a day. And so that's normally like, like your general 8 to 5, 8:30 to 5, what have you. And then on the flip side, I would be on the inpatient side. So whenever, my ER colleagues need the GIs for consulting for a GI bleeder, things like that, I will consult and see the patients, the hospitalists, if they need GI. So that's all inpatient stuff that I'll handle. So I really like that mix because especially as a new grad, you're being exposed to a lot, right? So whenever you're on the outpatient clinic side, like you're seeing you're seeing like the stable people, maybe procedure follow-ups, annual follow-ups and stuff. And but it doesn't get boring because you're going to the hospital. And so you're seeing really sick people, the sickest of the sick, right? And so it keeps things new and interesting. So again, whenever I see the patients, most of the time I am solo. I do a lot of my work, I guess, solo in a sense that I'm not physically with the doctors. Okay. So how they generally would supervise me is through, I write my note up in the clinic. If they agree with it, they sign off. We're all good. If they don't agree with it or they have further recommendations, then I make those adjustments. We notify the patient. Okay. And then we're good. Whenever I'm in the inpatient side and I'm in the hospital running around and everything like that, after I'm done putting in my notes and the orders that I want done, I'll call them up and then we'll run through the list. So once you get some experience with it, I mean, you'll find that, oh wow, this is pretty cool. Like I'm seeing all these patients, my docs are doing their own thing, outpatient procedures and everything like that, and I'm managing the list and everything, and so I'm catching them up. They're like, oh, so how's the list going? What's going on? And so it's after you develop that muscle and that confidence and you earn their trust, I mean, you'll find that, I mean, this role is pretty cool. Like you're doing the dang thing. um and we talked about, yeah, so it's a whole spectrum of what I see, from sick people to really stable people. And then I don't think you can ever escape this, whether you're a PA or a doctor, or, nurse, whatever. I mean, there's always going to be the fun administration work that we always look forward to, that takes up so much time at the end of the day, replying to messages and calls. And, I realize for every test that I order, it comes back to bite me because then I have to follow up on it, interpret it, and then see what the next steps are. So there's a lot of reviewing to do. So, it goes to show there's no wonder that we're always, looking at our screens and laptops and stuff, computers, rather than spending time with the patients, which is what we ultimately all want to do. But yeah, so that's a little bit more about what I do as a PA with my team. And so here we have my colleague, the senior PA, Koi Lang over here, and then myself. And so we actually will see between the 5 providers all of their patients. So I'm not mutually exclusive to one of the 5, nor is he. We just, if the patients need to see a follow-up or they need to see a provider, it's generally easier to see one of the PAs because we're not as booked as opposed to the docs, that are like booked sometimes like 3 months in advance, and like that's way too long, to wait. And overall, they're getting the same level of care. So more so on the inpatient stuff, the census, meaning the list itself, it'll vary. I cover up to 3 hospitals. Now it's a lot better. Primarily, we're hovering around just one hospital, the main hospital. But again, new consults are coming in from the hospitalist. New consults are coming in from the ED. I'm rounding on these patients daily, checking up on their progress, seeing if they need any more intervention and management from the side of the GI, or do I think they're good to go from my perspective and follow up outpatient, and we can handle chronic issues there. Again, 99% of the time, specifically, I see the patients alone. And so I guess I should also add that, this is going to vary, so it's going to vary between where you are in your career, whether you're starting off or you've got some skin in the game and you've been a provider for a long time. It's going to vary between, are you just now starting off with this, new employer and you have to, it's normal. You got to gain their trust, right? Just like with anything. Or if the provider itself, if they just, each provider to their own, right? How they handle things. And if they want you to see you more regularly, to have more oversight physically as to whenever you're seeing a patient and entering your orders and your thoughts on management and things like that. So it's going to vary. So yeah, we talked about what PAs can do and things like that, working up the patients. I interpret the labs and imagings as well. And so I prep the patients for procedures. So, and like in a perfect world, I'm doing as much of the logistics and handling everything to where I can just hand over the patient to my supervising physicians. They can do their scopes, see what they see, make further recommendations, and then it's almost like as if they're like giving it back to me, and then I take it from there. Like that's how I picture an efficient way of doing things with between the docs and the PAs myself. And then, like I said, with the procedures, as far as with GI, there's not a lot that we do as far as like scoping and everything like that. There are some APPs, like nurse practitioners up in the Northeast that I hear are doing routine colonoscopies. I don't know if that's going to catch wind or anything like that, but it's out there. And this is also going to vary between what specialty you're in, right? So there's first assist rows with PAs, and so you're in surgery, and so your role really is procedure focused. So this is going to vary between even like neurology, that's pretty procedure focused too, and other things like that. So it just really depends on what specialty you're in. I also work weekends, which kind of a bummer, I guess, to some people might think. But yeah, so I'm covering the hospital 1 weekend a month. I'm taking call with the supervising physician. So just in case we need to do a scope over the weekend, there's a doctor on the team that we can reach out to that will do that. And so, I'm taking phone calls again from the emergency department, from consultants, from the hospital side, and even urgent calls from patients themselves, so I can get a call about like, hey, my colonoscopy prep won't work and I have a colonoscopy planned on Monday, like troubleshoot, what do I do? Right. And sometimes it's part of the work, right? I'm awoken at 3 a.m. sometimes. That can be most of the time. That's because someone is in the ER and something's going on, right? So you have a food impaction. So usually it's like steak or something starchy, bread, right? And they feel like it's getting stuck in their mid sternum, and nothing they're doing is making it go down. And so that's technically a GI emergency. So we got to go there with our scope and we got to fish that out with a basket, or we kind of push it down and nudge it down with our scopes. Again, GI bleeders too. So somebody with cirrhosis comes in with bloody vomitus, we got to try and go in there and ban those little varices and stop the bleeding. Or there could be somebody bleeding from the rectum too. So those are the things that, unfortunately will wake you up in the middle of the night. And so the incentive to work on weekends really is either you get paid more or you get extra days off and stuff like that. So at least you should fight for that. Okay, so I wanted to talk a little bit more about the scopes that we do in GI. So the bread and butter two scopes are going to be your EGD and your colonoscopy. So whenever we're talking about these scopes, by and large, they all kind of look the same, right? I mean, if you look at the EGD and what the provider is holding, it's a long tubular camera, right? That you're holding on to. I mean, that's basically what all these are looking like. And so in upper endoscopy, we're looking at the upper GI tract. And so if you see where the scope is advancing through the mouth and down the esophagus, we get a good look there. We can see if there's severe inflammation there, if there's things that are consistent with Barrett's esophagus, which is due to long-term exposure to acid, and so somebody typically with a long-standing history of GERD. And so they get this changing in the lining of their esophagus. We can take a look at the stomach to see if there's any ulcerations there, any bad inflammation. And then we reach all the way down to the small bowel, the first part of the small bowel, to be specific, the duodenum. And so whenever we're advancing in these areas, we can do diagnostic things, including taking biopsies, right? And looking under the microscope to see, are there any precancerous changes? Are there Barrett's esophagus? Do you have a H. pylori infection? When we're looking in the small bowel, the duodenum, do you have evidence of celiac disease and, the villi, which should be like finger-like projections as we learned, right? But are they like blunted and, kind of flat? We can do therapeutic things too. So, I mean, if there was a food stuck there or, a food particle, whatever, we could push that down. If there was a narrowing in the esophagus, well, we can stretch it out. So there's a lot of neat stuff we could do. If there's a bleeding ulcer or something like that, we can cauterize it. So we can burn it, we can clip the vessel, or we can inject epinephrine and kind of let the vessel contract a little bit. So a lot of cool stuff you can do with the endoscope, with the EGD and stuff. Same thing with the colonoscopy. We can, but this time we're going up to the other end, right? The reverse, the rectum. So as we're going up the poop chute, well, first they got to prep. You got to prep the patient, which absolutely sucks, I hear. I think one day I should probably take one of the preps just to like really know what my patients are experiencing. But, the joke is it's go lightly, which is definitely not what happens. So, you purge the patient, clean out their colon so it's like nice and pristine. And then you're advancing all the way up from the rectum all the way down there to the end of the larger colon, the cecum. And then you can glance at just the first part of the, or the last part of the small bowel, the terminal ileum. So, I would do things like this if it was colon cancer screening, right? So it's that guy that's maybe age 50, age 45 now, where the guidelines are going. And they just, get their screening done. And, if we find some polyps, take it out, see if it's cancerous or precancerous and whatnot. If someone is having severe diarrhea, well, we're going in here to see if they have any evidence of inflammatory bowel disease or microscopic colitis and taking biopsies. If someone is like severely constipated and things like that, sometimes you got to worry about a mass, right? And hopefully that mass is not cancerous, but the only way you're really going to find out is if you do a colonoscopy. So those two are like the bread and butter scopes of what GI does, but there's more. The other scopes that we do, as I talked about earlier, are the EUS and then the ERCP. So if we talk about the EUS real quick, again, it's like these are all long tubular cameras, right, y'all? So, but at the end of the EUS scope, I guess, or the endoscope here in the sense, there's an ultrasound probe, right? So you're using ultrasound technology to create, get a better picture idea of physically of what these organs look like. You can look at the common bile duct. So sometimes if it's not a clear picture, does this person have a common bile duct stone or not? And this is after we're doing an MRCP sometimes. And I'll talk about more of that later, but you can advance somebody with the EUS first. Take a look at the beautiful common bile duct. And if it looks normal, then we probably don't need to do an ERCP. But that's cool because we just saved them an invasive procedure, right? So with the EUS, we can also look at the pancreas too. So sometimes that's somebody that has acute pancreatitis in the episode, but we just can't find the reason why. And so, a few weeks down the road after the pancreas cools off, we'll look at it physically with the ultrasound, and then we could get a better characteristics of things. And we could potentially take biopsies too of the pancreas. The other test is the ERCP. And so again, long tubular camera goes all the way down to the area of the duodenum. You'll find the ampulla, and that's going to be the gateway into the pancreatic duct and the common bile duct, right? Because they're going to meet together at the ampulla, which is going to empty out into the duodenum, small bowel. So here in this ERCP, we can advance all the way up into the common bile duct. We can inject dye in there to see if there's any obstruction. We can look at the bile ducts within the gallbladder, within the liver too. If there's a stone up there in the common bile duct, we could take it out. If we think there's some evidence of cancer going on in here, we could take biopsies of it. If we go over here into to the pancreatic duct, we can insert a stent in there if there's maybe an insult to the pancreatic duct and there's a leakage. Maybe there's just chronic pancreatitis and someone is just prone to having the duct strictured, and that will cause a pancreatitis episode in itself. So, there's a lot of neat, interesting things we can do with the ERCP. So again, it's both diagnostic and therapeutic. And then I want to mention the MRCP because I don't know, I got confused whenever I was a student, but whenever you're doing an MRCP, it's an MRI based study that you're really trying to get a good look of the whole biliary tree, right? So all that green tube that you see in an anatomy book, that's pretty much what we're trying to characterize, right? So the pancreatic duct, the common bile duct, the gallbladder, the intrahepatic ducts, we're trying to get a good picture of that. And so I commonly will order it most of the time to see if there's a common bile duct stone in it. Common bile duct stone, and that we would need to intervene first. And so it's just diagnostics. Of course, you can't do anything with the MR study if it's positive, right? You can't treat them or manage them. So it's strictly diagnostics. Okay, and then lastly, scopes that are going to allow you to view the small bowel. So you have one way of doing it is with the capsule endoscopy. So it's pretty cool. You have this patient come into your office or whatever in the hospital, and they're going to have this pill that's about this big, and so they swallow it. And then it's going to take a bunch of pictures and recordings and things like that, and they wear this transmitter that translates all of the footage and everything. And so the endoscopist it's like a long video, and so they'll follow it as it goes through your small bowel and look for like hidden bleeds that you couldn't find whenever we're assessing with the EGD and the colonoscopy. So up top, down low, can't find nothing. So we're going to go into the middle, and we're going to go into the middle because we can't really get that far in going up from the EGD or down below with the colonoscopy. So this is pretty cool because it's not invasive, right? I mean, they're swallowing the pill, go about your regular day. They don't even notice, but they're going to poop it out, and we definitely don't want it back. We just want the transmitter back. And, it's the downside is that you can't do anything about it, right? It's not therapeutic. If you find a lesion, like something that's bleeding, then you're going to send them off to get endoscope. And so you might want to do a double balloon enteroscopy, depending on where it is. But we don't we don't do this in our practice. This is pretty specialized and advanced to where, it's going to be done like here at UT Southwestern, right? At a teaching institution, or very few providers have been trained in this. So it's not far reaching and common in a sense. But these two things you can use to assess the small bowel, the middle of the GI tract, essentially. All right. So with that said, we talked about some of the diseases of what in gastroenterology, what a PA does and everything like that. And then the scopes, our tools, and why we're so useful in the management of the patient's care. So let's kind of hone everything together and do a quick little case study. So just move this. So we have a 47-year-old dude. He has a history of GERD. He was referred to your clinic for epigastric pain, so right below your breastbone or in the lower breastbone region. And he said it's painful, feels full, he's nauseated, but he's not really vomiting. There's some bloating going on from the last 3 months. He does say it's worse with meals, but doesn't really identify any patterns or anything or specific meals. Again, you ask him about NSAIDs. We always ask about NSAIDs in GI. And so he does take BC powder, right, for headaches. And you go into your ROS, just make sure you're not missing anything. There's no fevers. His weight is fine. He's eating okay, no anorexia. There's no hard time swallowing. He hasn't noticed any bleeding, so not throwing up blood, not pooping out blood. Really no lower GI symptoms. His bowels are okay, essentially. And he does have a history of smoking. Family history is negative. And so his vitals are okay. His exam, it's all good. He looks good. And so, differentials and things like that, I'll just kind of, if this were me, I would look at things like, epigastric pain. If we kind of pull our focus into, one symptom and try to create a differential with that, epigastric pain, I'm thinking of ulcers, I'm thinking about gastritis. So it's things of the stomach focus. You can also have referred pain and such too with gallbladder issues. Yes, typically it is right upper quadrant, but it can also affect the epigastrium area as well. So, I mean, you could throw that into the differential as well. And so we're prioritizing things as we're thinking about this, right? Probably peptic ulcer, something like that, less likely to be gallbladder related. Epigastric pain is also classic of pancreas too, right? So your pancreas like wraps around in that region. And so, but I mean, this is going on for a long time. Usually somebody with pancreatitis, I would think would be presenting because of the extreme abdominal pain and, probably they're dehydrated, that they would be in the hospital being evaluated for that. So, I mean, those are some things within the differential. Okay. You can always blame things on like diet, on medicine. I didn't really go into his medical history outside of the BC powder, but those are things to consider. Cancer is always on the differential. It's always on the differential. Can't ever say it's not. So those are things to keep in mind.
Philip, this is Dr. Fowler. One of the things I'd wonder is that, does he take his BC powder with just a little swallow of water as opposed to taking it, with a fair amount of liquid, just as part of the history?
I didn't even think twice about it. I've never taken BC powder myself.
BC powder is mostly aspirin, and if they take it with just a little swallow of water and puts that salicylate, in contact with the gastric mucosa, as opposed to, really putting a lot of water down there, which makes it less likely that it might ulcerate the stomach.
Yeah. Oh, that's a good point. Thank you for that pearl. All right. So we talked about the differential. Okay. And then we move on to labs. So, we order basic labs, CMP, CBC, thyroid, lipase. Lipase is for pancreas stuff. All normal. Okay. Again, this is also in the clinic too. I don't know if I said that, but yeah, this is outpatient in the clinic. At this point, I think it'd be reasonable if we're considering imaging too, as far as what's the next step after you order your labs and everything. But, also I note here, okay, so he actually did have a CT abdomen and pelvis. So it's always nice to double check and ask the patient what they have done instead of just relying solely on your EMR. I've been burned a few times like that. So I'm always the one to double check. So he was like, oh yeah. Like last month, he actually did get a CT of the abdomen and pelvis and it looked fine. There's some fatty liver changes, very common. Diverticulosis, so a little outpouching of the colon. But otherwise pretty negative, right? So nothing remarkable to explain why this guy's feeling what he's feeling. And so you're thinking, all right, so he's had labs done. He's had imaging done, cross-sectional imaging. So, next up, you might think, well, okay, he's in the GI clinic. What do we do best, right? We have access to endoscopies and tools. So probably you guys are thinking, yeah, let's go ahead and tease the idea of doing probably an upper endoscopy, right? Because he's having upper GI symptoms in the epigastrium area. And so he ends up getting an endoscopy done. And so we're checking the upper GI tract. Let's just say the esophagus looks good and everything, but as we're advancing into the stomach, you notice some ulcerations and things like that. Classically, it's going to be in the antrum and things. So take a biopsy of it, and then lo and behold, it comes back positive for H. pylori. H. pylori living in the gut. And so, yeah, it can cause this picture of indigestion. And, this is a disease of decades, right? Like you're infected in childhood, and then it really doesn't cause problems until later on in adulthood. Some kids do get H. pylori infection as well. But, it's very interesting. H. pylori is just so interesting in that sense to me. But yeah, so he found out he has H. pylori, which is great. So now you have a cause for his indigestion issues, right? Epigastric pain, bloating, nausea. So we know how to treat that, and that's an antibiotic-based treatment. So with regards to treating H. pylori, I wanted to emphasize a few things. So I know in textbook, in school and stuff, we're classically taught about clarithromycin, amoxicillin, and a PPI, right? That's CAP therapy. But really, in my experience and in real world, I find that outside of being very affordable, it's not the best treatment because there are better stuff out there. There's increasing resistance with CAP therapy, more so with the clarithromycin resistance. And I really don't know how to find the antibiotic bacteriogram within an area. So that's something that they say to look up and stuff. But in real world, I mean, we just don't do that. But the best alternative, I feel like, is going to be bismuth-based quadruple therapy. So if you want to take one pearl away as far as H. pylori into medicine, into real world practice, it's going to be bismuth is almost always the right answer. So bismuth quadruple therapy to treat H. pylori is going to be bismuth, tetracycline, flagyl, and a PPI. And so why I love it so much is, okay, if this is a dude's first H. pylori infection, give them bismuth quadruple therapy. If they have failed like CAP therapy or some kind of therapy before, the next best thing is quadruple therapy. If they're allergic to clarithromycin, quadruple therapy. It's just beautiful. I mean, if you just remember quadruple therapy, and look it up on Hippocrates or something, you probably did the patient a lot of good. Other therapies to treat H. pylori infection include load therapy. So that stands for Levaquin, omeprazole, Alinea, and doxycycline. So it's a Levaquin-based treatment. Concomitant therapy is going to be CAP therapy with flagyl. And then we have something new on the market, Talicia. I've actually already used it a few times, but it's pretty neat. It's going to be a rifamycin-based therapy. So you're using amoxicillin, a PPI, and then now rifabutin. So it's pretty cool. You just have to warn the patient that it might turn their secretions. So, their pee red orange, right? So, which is okay. They still should finish it and continue it. But yeah, so those are all different ways you can treat H. pylori. But I would encourage you to, do the quadruple based therapy because, I mean, you're almost never going to go wrong with that, provided they could tolerate it. There's no allergies or anything. And then so after we treat H. pylori infection, right? So we treat it for about 10 to 14 days. This is one of the diseases or infections where we actually do want to treat for eradication, right? The best H. pylori is a dead H. pylori is what I was told. So we want to make sure that sucker is dead, right? So we're going to test you with a urea breath test after treatment in about 6 to 8 weeks. And then, during that time, you're off of PPIs. But if that test is negative, then it's pretty sensitive. That tells me that you do not have the H. pylori infection anymore. And so, I mean, that's a big deal, because later on that could lead to cancer and such and whatnot. So it's one of those things where when we treat it, we aim to eradicate it fully. We don't always do that, right? Like with C. diff, whenever we're treating that bacterial infection of the colon, after you're done with the 2 weeks of therapies and such like that, if your symptoms are better, we don't even go ahead and make sure you're confirmed to be eradicated or anything like that. So we take H. pylori seriously. Okay, so the wrap up, get it? Because that's a wrap. Gastric ulcers. Okay, so ulcer disease, gastric ulcers, whatever. I mean, they're going to be caused mostly by NSAIDs just because they're readily available. It's over the counter, and we love to use it. It's a band-aid over the problem, right? Our joint pains and things like that. H. pylori we talked about earlier, but also steroids, right? So you're a rheumatologic patient that has RA, and so maybe they're on chronic steroids, or they're getting steroids quite often. Physiologic stress. So these are the patients, like for instance, in the ICU, right? And they're just really sick and under a lot of stress. Their body's under a lot of stress. Alcohol can be an offending agent that can cause ulcers. Tobacco, we know, and cancer. Cancer can present as a gastric ulcer, and so that's why we need to take biopsies of it. So the wrap up, he completed his bismuth quadruple therapy because you remembered, hey, quadruple therapy is always the right answer. And so his following breath test is negative, and you just look like a stud. You cured him of something. He's doing well on the acid reducing medication as needed. And you even threw in some tobacco cessation. So, kudos to you. We just did a patient a lot of good. And okay, so then moving on to case study number 2. This is going to be, now we're flipping side into the inpatient service. Okay, so let's see, hopefully this is a good presentation. Dr. Fowler, feel free to chime in. This is a 40-year-old male presenting to the ER with epigastric pain for the last day. He notes multiple bouts of vomiting with no blood in it. He does admit upon further history that he's a chronic alcohol. So he uses alcohol pretty heavily. In the last few weeks, he's used it more. I mean, during the pandemic, it's people are losing their jobs. Unfortunately, it's hard economically for us. So you can understand why he's feeling more depressed and more inclined to reach for alcohol to mitigate all those feelings. So no past surgical histories. He's actually had similar presentations like this in the past this year. So upon presentation, you can read his vitals. He's pretty stable otherwise, no fever. His CMP is okay, so his metabolic panel is all right. Creatinine's a little bumped up, so it may be a little dehydrated. Hemoglobin 16.7. His AST, ALT are a little bit bumped up too. More so his bilirubin and alk phos are also elevated as well. And then, he's expressing epigastric pain. So you were like, okay, so, pancreas is on your differential. And so you order the lipase and whoa, almighty, it's jacked up. It's all the way up to the 3000s. And so upon examination, you're touching his epigastric area and it is tender to touch to you. Otherwise, he appears okay. He might be a little jaundiced too, but, let's see. So you get imaging. So
if I can comment in the emergency department, I'd be concerned about this guy before the imaging, because with the tachycardia, with him lying in the bed, I'd be concerned, especially with him vomiting. He's at least dehydrated. As you said, the creatinine is elevated at 1.46, indicating it could be acute kidney injury or just dehydration. Mm-hmm. But he actually could be borderline shocky, so I'd be a little concerned about him.
Absolutely, yeah. And that's why I'm glad to have my colleagues there to back me up in that sense. But we order imaging as well, and then the ultrasound shows no gallstones. But whenever we're doing the ultrasound of that area, we can also glean into the common bile duct and roughly estimate, how dilated it is. And so it's noted to be dilated in this sense to 9 millimeters with a little bit of tapering. So putting that all together, you're wondering, at least from the GI focus, you're thinking, is there some kind of pathology, something brewing up in the common bile duct, right? With those AST, ALT levels and the bilirubin and alk phos being elevated in a cholestatic pattern, right? So, also in a sense, he not only got an ultrasound, but he had a CT done. The question of with or without contrast, we would want it in this case with IV contrast, because we were really wanting to look at the pancreas and the parenchyma, so the actual pancreas tissue itself. And so we do that, and the imaging shows that it is consistent with acute pancreatitis. Thankfully, we don't see any signs of complications, so like necrosis or anything like that. Again, and with the CT, it does show that the CBD, the common bile duct, is dilated too. And so as far as, what I'm thinking of is going to be, okay, this guy is obviously presenting with pancreatitis, right? You need 2 to 3 to make the diagnosis. The abdominal pain, either your lipase is elevated or you have CT imaging consistent with that. So in this case, he actually has all 3, right? Which makes sense with the symptomatology of things. And so let's see, we agree as a team to admit him for acute pancreatitis. In this case, based upon our history, we're concerned, we think it's secondary to alcohol use. And so, let's see. If we jump to other causes of pancreatitis, I mean, the most common two things we're thinking about are going to be alcohol use and going to be gallstone or termed biliary pancreatitis, right? But there are other causes for pancreatitis. It's not unheard of to see somebody maybe with out of control diabetes and things like that presenting with hypertriglyceridemia. So your blood is just filled with hypertriglycer or with triglycerides, and so I mean you really have like bacon grease flowing in your bloodstream. So that's another cause of an inflamed pancreas. You can have cancer presenting as pancreatitis. You can have autoimmune pancreatitis, genetic causes for pancreatitis. And then let's not forget iatrogenic causes after ERCP. I didn't mention that earlier, but as we're finessing with the pancreatic duct and stuff, we can always have potentials. We can potentially cause an angry and inflamed pancreas afterwards too. Medications as well. So the differential is pretty wide for the causes of pancreatitis, but the two that you should really keep in mind are going to be alcohol and gallstones. Okay. So
another cause is mumps, of course. Viral mumps actually can cause acute pancreatitis.
Yeah. The classic, was it a scorpion sting? Is that right, Doctor?
And yeah, very good. Scorpion sting. Yeah, that's true. You're right.
Have you all ever came across that? Because that would be so neat.
It would be a place where you see a lot of scorpions, a place where there's a lot of woods, but yeah, it's out there. Sure.
That's quite interesting.
Good point.
Yeah. So, okay. So we talked about other causes of pancreatitis. He's admitted for that, and we'll speak about the management in a little bit. But I also created this case study to kind of dive in a little bit more. So again, with those abnormal imaging findings and the cholestatic patterns, meaning the bilirubin was elevated, the alk phos was elevated, you'd at least want to explore further into the common bile duct to see if there's any pathology going on in there, i.e., like I'm thinking, all right, does this dude have a stone, right? Is there a stone that the GI folks need to possibly perform a procedure on and take out that stone? And so as I'm thinking about that, you're essentially weighing, all right, do I want to do an MRCP or do I want to do an ERCP, a procedure first? Okay, so moving on, we'll talk about that and wrap it up with the management. So this guy comes in with a classic history of pancreatitis. So the paramount thing with pancreatitis is you have to bombard them with fluids, right? Usually by the time I'm consulted and everything, that patient has already gotten about 2-liter bolus of fluids, right? So I always, I think about the pancreas as a little sponge, right? It like as if it's soaking up so much water and things like that. And keep in mind, I mean, these patients are vomiting, as in this case. He's also not drinking as much too. So he's creating this vicious cycle of being volume depleted, right? That's why his creatinine was up. That's why he was hemoconcentrated and his hemoglobin was around 16 and such like that, right? So these patients that are presenting with a pancreatitis, they're just volume depleted and they're thirsty. Okay, so we're flooding them with fluids. Usually after the 2-liter bolus, I mean, they're running fluids at like, 200, 250 cc's an hour. So it's very paramount within the first 24, 48 hours. We're trying to get them as much fluid as possible. So that's number one. And the question of monitoring that person, so the next day on rounds and stuff, I will actually not check the lipase. It's not part of my management. There's very narrowed reasons why I would check the lipase. But in general, as I'm following the patient and hopefully they're progressing well, I'm monitoring things like, are they getting enough fluids? So I'm looking at the creatinine and the BUN. So the next day, I'm hoping those numbers will go down, right? I'm hoping I can dilute his blood too, right? So his hemoglobin hematocrit will go down too. So those are indicators to me, as well as monitoring his his ins and outs and urine output, that this gentleman is getting enough fluids. Next in line is going to be pain management, right? So pancreatitis, severe pain, right? And this guy is like tender on exam and everything like that. So pain management is paramount, making sure they don't vomit anymore too, right? Because this guy is already, he's already dehydrated. Nutrition is also important too. So the question to keep him NPO or not, well, I mean, in this case, he was vomiting, things like that. I probably wouldn't just allow him to eat right off the bat. But I throw this in there because you don't always have to wait 24 hours or 48 hours, whatever, before feeding the patient, because nutrition is key here. Especially on top of the fact that he's a chronic alcohol user, right? So he's already prone to not getting enough nutrients in his diet already. So what I mean to say is, sometimes if it's a mild pancreatitis and, this patient, usually I'm asking them, hey, are you hungry? Do you have an appetite? How's the pain doing? And if the pain is better, if they have an appetite, and they're not throwing up, then to me, that's a good indicator that I can advance the diet accordingly. In some cases, I'm like, all right, you can go ahead and eat a low fat diet. In some cases, or start the clear liquid diet, making sure you can handle that and not throwing up, and then go straight into a low fat diet. But nutrition is very paramount in this case too. Consider stopping offending medications. So if you're finding in the medications like diuretics and such like that, sometimes like immunosuppressants, that falls in line with what I do. So azathioprine, any offending agents that you could find that you can stop, I'd probably stop that too. That can cause a pancreatitis. Bowel regimen. So, I start everyone on bowel regimen. I mean, they're not eating too much. They're getting pain medication, so they're already prone to constipation. They're not moving too much. So that's something you can consider. So that's, yeah, in a nutshell, I mean, just remember fluids, right? That's going to be the number one thing in this case. And as Dr. Fowler was alluding to, I mean, he already appeared septic in a sense, or, you were worried about that too. So that's very important.
Philip, the picture of pancreatitis is one that's kind of a moment in time. We score these with a thing called, as you know, the Ransom criteria, which is abbreviated Georgia law. G is for glucose, elevated glucose. A is for age 55 or above. L is for LDH above 350, AST above 250, and W is for white count above 15,000. I bring that up only to say that these patients sometimes get worse, and they indeed can go into shock and altered mental status. So pancreatitis, whenever we see it, is kind of a moment in time. We hope they don't get worse. And as you say, we hydrate them, maintain their vascular status, but we sure have to watch them, as you were pointing out. So you did put it. So you put a stent in this guy, huh?
Is it? Yeah. So number 6. So in regards to the question of the common bile duct pathology, we decided, hey, let's get some further imaging done. Okay. So we ordered an MRCP, and so I don't think I mentioned this earlier, but with this study, we're not using contrast, right? This is a contrast-less study. And so really, again, we're looking at the bile ducts, the tubular systems, right? I'm not really worried about the pancreas here because the CT imaging shows that there was some inflammation consistent with pancreatitis, but not a lot of dangerous stuff was brewing up. So we get an MRCP study. It shows no stones, actually, okay? But the distal bile duct was still narrowed. And so with that, I mean, this is probably because, in the history, he's had pancreatitis before, twice this past year. So, I mean, this could be an inflammatory stricture, right? So, where the common bile duct courses, right there at the head of the pancreas, right? Inflammation to the pancreas can cause some narrowing in itself to the common bile duct. So, in our decision, we decided to stent him. So with the MRCP showing a narrowing there, we pursue with the ERCP. So we drop a scope in there, we advance up into the ampulla, and then, we'll probably do a sphincterotomy. So open that up a little bit, and then we'll advance a plastic stent, right? So you have your metal stents and your plastic stents. Your metal stents are probably going to be there for, you place a metal stent because it's going to be there forever, right? You don't have any intentions of taking it out usually. And usually that's somebody with, malignancy and for palliative measures and things like that.
Peter, I'm sorry I said Philip a moment ago. I apologize. Peter, alcoholic pancreatitis is its own unique disease, and you just about have to drink yourself damn near to death to get it. And so, it's really important. And this guy can't drink. And so will you get him involved in counseling and that sort of thing?
Yes, I would absolutely. I think I should have mentioned it in the wrap up there, but yes, I would absolutely, especially when he's in the hospital, Dr. Fowler, when there's, your social worker colleagues are more readily available to kind of help with situations in that sense. But yes, I would absolutely counsel on alcohol cessation because, he's putting himself up for another episode of pancreatitis. And then that in itself is going to lead them into, a chronic picture of chronic pancreatitis. And, not every pancreatitis issue is going to, in this case, I'm painting a picture of a relatively benign hospital course. Complications, as you were alluding to, Dr. Fowler, a necrotizing pancreatitis, right? Things can get infective and, now you're having this dead necrotic tissue and surgery might have to be involved. We might have to be involved with further invasive procedures. IR might have to be involved and drain some things too. These patients could get full-blown septic.
And especially when someone continues to drink, they can get into a necrotizing pancreatitis where that organ actually breaks down and can kill them. So this is a tough problem.
Oh yeah.
Go ahead, Peter.
Yes. And so, yes. So thank you for that. So yeah.
Do you leave that stent in or what, do you take it out eventually or what do you do?
Yeah. So good question. So we do the ERCP, we decide to stent this fella for relief. And so we put a plastic stent in there, right? So we're putting a plastic stent into the common bile duct. Okay. And we're going to leave that in there for a few weeks. So typically what I'll do is, okay, so let's do the wrap up real quick. So his admission, thankfully, it's without any severe complications. He does well with the IV fluids we give him post ERCP. So after we do an ERCP, I'll typically watch them for 24 hours just to make sure there's no GI bleeds or anything like that, or any worsening abdominal pains to suggest like a perforation or things like that. And so he does well with it. He tolerates liquids. We advance the diet to low fat. And, he's weaning out the IV pain meds. Okay, so I did add that on there. Counseling on alcohol cessation, as Dr. Fowler was alluding to. So he does well. And so he does need the removal of the plastic stent. So I guess now that I'm thinking about it, one of the things you might want to consider is, you yourself, you just placed a plastic stent into a patient. And so these plastic stents can lead to an infection that's why they're not really meant to be left in there long term, right? So you want to first make sure the patient is going to follow up with you because that's going to lead to problems later on down the road if you don't remove the stent. But typically what will happen is, I'd want to follow up with this patient. And in this sense, since this is a recurrent pancreatitis for him, I probably want to follow up in about a week or 2 weeks at most, just because I just want that close follow-up. I already established a relationship with him. I want to make sure that, I could be a support system and a resource for him as he's, as I'm suggesting, he's quitting alcohol. And then after he sees me, I'll usually schedule another ERCP with stent management. So one of the endoscopists will remove the stent in about 4 to 6 weeks. And then after that, hopefully he's all right. Hopefully he doesn't drink anymore, but that's typically how we'll manage a plastic stent in this sense. Does that answer your question, Dr. Fowler?
Yeah, I was actually, I don't have any experience with the stents being placed because I always send them upstairs to get that done. Mm-hmm. We actually had a question from one of the students. Is there a dissolvable stent or do they have to be taken out?
There is not a dissolvable stent that I know of. Now, I did have an interesting case of, we saw a patient recently, actually, and she had history of, common bile duct stones and it needing a stent and everything. So we placed a plastic stent. Given this was about 3 years ago, right? So we had the intent of taking the stent out. and retrieving more of the common bile duct stones that we couldn't before, right? He or she never followed up. And so we're wondering what happened to the stent. And on repeat x-rays and even a CT scan, there was no evidence of the stent. So, the stent can potentially pass on its own too, but that doesn't rule out the fact that we still need to go back with the ERCP and do our due diligence and remove that plastic stent. So no dissolvable stent that I know of, but I mean, that sounds like a good idea. I like the way that person thinks. Okay. All right, so that kind of wraps up this case. My colleagues, is there anything else further as far as this pancreatitis case study that you would all want to add on to, or anything else you think I maybe overlooked?
This is one of the
Peter, you see a lot of stuff where folks sadly, unfortunately, injure themselves, for example, with drinking. And so for example, the esophageal varices that you talk about banding, for example, where people can literally bleed to death and drown in their own blood. As ghastly as that sound, it's absolutely true. So you end up having to care for a lot of people that unfortunately don't take care of themselves very well sometimes. And how do you deal with that philosophically? I mean, how do you keep for example, from getting judgmental and say, look, you are drinking yourself to death? Or what do you do about that?
I think that's a really good question, because that's something that I grapple with. Like, I'm not perfect. I think especially early on in my career, I don't want to be jaded, but I think, irrespective of how the case is presenting, I had to physically remind myself, or mentally, that I must take out all the bias, because at the end of the day, this patient is a life. They still deserve the appropriate workup that you would give if this was your mom, if this was your dad. They still deserve the excellent care that you were trained to give. And so, that's how I think of it. But you're absolutely right. I feel like, there are times whenever I do get jaded, but I try, those are those biases that I feel like are inherent, but those things that we need to recognize and be cognizant of, and, try to grapple with and do better with.
These patients get marginalized, their entire adult life, because they have a substance abuse disorder. And all of us are guilty of it. But I really like the way you put it, Peter. At the end of the day, they're somebody's father, somebody's son, somebody's brother. So somebody really loves them. And so they get marginalized because of a disorder. And it's not a choice. It's a mental health disorder. So I'm glad our young learners are beginning to recognize that there is a big difference, and you can get jaded too as a clinician. It's very simple.
Yeah, I absolutely agree. Well, I really like this format, because usually when I'm doing a presentation, I don't get this, this open discussion and everything like that. So I love it.
And I have two other quick comments,
Yes,
Peter, if I may, just to say that, number one, when I'm dealing with such patients, if I really do feel like my conclusion is accurate, that this is an issue where, in this case, alcohol, I want to make sure they heard from me that, sir or ma'am, I want you to know that what you are doing is hurting you. I want to be clear that you've heard that, and that we must move forward as partners in your health to try to help you move to a different space. The other thing, and Peter, this is just my last quick comment, is you've also not to get jaded and assume that is the problem, because it may be that they're drinking, but actually it is a stone in the common bile duct. And that's actually, or it's a stone jammed in the ampulla of Otter, or the sphincter of Odie. And while I'm assuming that their pancreatitis is due to the fact that they're drinking a fair amount, in fact, they've got a gallstone sitting.
Yes. I absolutely agree. And so, thank you for asking that question. That was really insightful for myself too, to think about that and remind myself, it's those biases that we need to be aware of. Thank you, Dr. Fowler. Okay. So if I may wrap up and move on. So after the case studies, just some general pro tips that I have. Whenever I say keep it pH 14, I mean, there's a lot of overwhelming content and things to learn in med school and PA school, what have you, whatever area of studies. But I would stress keep it broad and like from a primary care focus, because you're going to get stuck in the rabbit hole, and that's just poor time management. So, give yourself a little bit of grace and learn a little bit about everything, because I mean, hey, you might end up in a specialty where, I mean, your focus may not be, X, Y, and Z. It would be primarily this and that. So don't get caught up in the weeds. It's basically what I'm trying to get at. I talked about my spiel on scholarships and everything like that. Tuition is rising. I don't think it's going to go down any day soon. So the debt, the reality of debt is that it's real. It's sitting at 1.6 trillion right now, right? So, I mean, take advantage of the scholarships and what you have access to, and really, like I said, it's all about volume and apply to as much as possible. It's great if you get the full ride, if you get, tens and 20s, thousands, 30,000s of dollars, but, even the few $1,000 to $5,000 scholarships, they're going to do you a lot of good. And again, they're tax free. So, I mean, that saves you some money there too. I always emphasize networking, planting seeds, getting to know other people, seeking mentors. I feel like this is a perfect platform for this. Dr. Salazar, Dr. Fowler. I mean, you're already in network with them. And so I feel like in real world, after you're graduating, again, it's not the school that you went to, right? It's the people you know. When you're applying with the recruiters, I mean, they're filtering you, right? There's no really face to, the resume that they're reading. It's all about networking. And so I really would stress that you would really embark on that. And when I emphasize networking, I think it's a two-way street. I think, with this whole program, there's something to be gained by working with the physicians, but also you're providing something to them too, right? I'm sure the whole, and you could correct me if I'm wrong, the whole logistics of this platform would collapse without the students that are willing to help and things like that, right? The tech savvy students. So it's very much a two-way street. Whenever, in my example, whenever I have students in clinic, I'm asking you questions, not, to like pimp you or anything like that, because, I myself, maybe I need a reminder or I want to learn, whatever. So I'm looking for you to provide something to me too. So I keep it as a two-way street. Financial literacy is something important to me because, loans and debt and things like that. It's, you're not taught that in school, and definitely not in medical training and stuff. But, you're walking out with what, $200, $300, $400,000 worth of debt, and no one has told you how to manage that. Like, that just sounds so crazy to me. So I would also work on that too. And then lastly, burnout, being cognizant of that, I think is wholeheartedly something that you should work towards, because it's going to happen. And I know my ER colleagues can really attest to that, because, with all that's going on in the pandemic, it's impossible not to be burned out right now. Morally, we're hurt, right? We're hurt seeing, how this is politicized. We're hurt by seeing patient outcomes and things like that. So just finding out something that, can really mitigate that and kind of, heal your soul up, if you will.
A friend of mine, Peter, says that burnout is the response of a normal person to a toxic condition.
That is deep.
You take a normal person, you put them in a difficult enough environment, and they will begin to wear out.
Mm-hmm.
And that's the truth.
Yes,
Peter,
sadly, we're 10 months into COVID right now, and a lot of us are pretty tired.
Rohit and Peter, is it okay if I ask the first questions? I'm really curious, if I might.
Please.
I absolutely love working with nurses, PAs, nurse practitioners. Mm-hmm. There's a give and take. I learn a lot from them as they learn from me. Now, I'm curious from your perspective, what do you look for? What are the characteristics of a physician that you value so that our learners here can learn to kind of integrate those qualities as they work with other members of the healthcare team? So what qualities do you value in a physician that you work with?
Okay. I really value a physician colleague, someone that is willing to teach me, because I'm wanting to learn. And especially, I still feel I am a new grad, right? I'm 2 years out. I want to learn. So, that's why I miss the academic settings, to be honest. But someone that's gonna be there for you and at least meet you on the 50, right? I don't want anybody to do the whole work for me, the whole workup. This is the, this and that. Like, teach me. I'm going to, for instance, see the patient, gather the history, formulate a differential and a plan. And so this is what I think should be done. What do you think, sir? And so I like to collaborate in that sense too. So that's really big on me, whenever I'm looking for a physician to work for, because I want to learn, but I also want to be of value to you too. And so I think that's how it should be.
Well, I think the way Gil put it is so important, Peter, is that we are all working together as colleagues. It ain't the docs, it ain't the nurses, it ain't the techs, it's not the NPs or the PAs in the ER. It's all of us together as partners to try to address improving the health of those that we serve. It is a service business first and foremost. And so we adore the advanced practice practitioners that we work with at Parkland. They are a mainstay of the work that we do there. So I just want to congratulate you. You went through a great school, and you're doing a wonderful job in your gastroenterology work. So we are just deeply humbled. And by the way, I want to say to all 600 people still online, would you please all put a thank you, Peter, into the chat right now, please? Let's show him 500 thank yous right now. Look at those things. I hope you can see it, Peter, because we deeply appreciate what you've done. Rohit, do we have some questions for our guest?
Yeah, we've got plenty of questions. One of the more popular questions was, what were the deciding factors that helped you make up your mind in switching over from pre-med to PA, and specifically not nurse practitioner, why PA?
So I'll say that, medicine was always my mindset. Now I know, they'll say the difference between the PA route and the NP route, while both being advanced level providers, is, you have your nursing model and you have your medical model. And so the amount of hours that each individual is required to train is also going to vary too. But I will say at the end of the day, as far as in clinical practice, there's really not a ton of difference, like everything that I described that I'm doing, a nurse practitioner, a colleague of mine too. There shouldn't be a dichotomy, they're, like Dr. Fowler was saying, we're all in this together. They're colleagues of mine. They can equally do what I do, if not better too. So, but to that end, teasing apart why I switched over to the MD route from the PA route, it was really more of a personal decision as far as, the timeline of things. I didn't foresee myself being in schooling that long, to be honest. And the debt burden was not something that I myself was comfortable with. And taking all that into account with my personality, again, the hierarchy of things, I know it shouldn't be that way, but I think it's there. The reality of it's there. And so that didn't quite bother me. At the end of the day, I look towards patient care and the role that I would play. And I do feel today, there's no regrets. I still feel the fulfillment of what I do. And so taking all that into account, I felt that the PA model or the PA route was more in line with my values.
Thanks for letting us know. As a physician assistant, are you able to conduct or collaborate on research?
Yeah. So I know some colleagues, especially more so on the academic side, that are able to, collaborate with research with their attending physicians and things like that. But yeah, I guess as you would have noticed, like in the pre-PA slides, research is not as heavily emphasized. Not to say that, those in undergrad don't do it as they're pursuing PA, but there's not a lot of emphasis on that. So that's why I myself never pursued such things in my career or early on.
How is the autonomy of PAs and GI in comparison to other specialties like pediatrics or surgery?
Well, I feel like that's such a hard question to answer in a black and white manner. The variation of it, and one that one might consider, is, the personality of the supervising physician or physicians, in the workflow in that little pod. Okay. And then I guess specialty too. Of course, like you mentioned surgery, for example. I don't think a PA is going to start operating and everything without the attending physician there, right? But autonomy wise, like I've seen, I was doing ortho shadowing, so the orthopedic surgeon was over there operating and cleaning out the knee and everything like that. He just gave the quadricep tendon to the PA, and he just had that it, creating the new ACL for the patient. So and if that kind of answers your question. So it varies, but I find that also as you're gaining the trust, as you're building your clinical confidence, you're granted more of that autonomous route, that autonomy role, but you're still in touch and collaborating nonetheless with your team and with the doctors as well at all times.
Yeah, that makes a lot of sense. Another question we had is, are there any instances where you don't know how to diagnose and treat the patient? And if so, how do you handle the situation?
When I'm just like, I don't know what's going on.
Yeah.
Yeah, I mean, sometimes that's like right. If my colleagues can attest to that, sometimes that's just medicine. Like whenever the patient presents, and you don't have all of the information that you like in my note too. I'm seeing pending results to see if endoscopy is needed, pending clinical progress and things like that. So, um, how I handle it is, yes, I would talk to my supervising physician too. And, I'm never shy. I'm honest. Like, hey, like, what do you think? I'm kind of thinking this, or is there anything further you would add to the workup? Um, and then I'm never shy to admit to the patient, like, hey, I would never lie to the patient and just make up some bull crap, right? Like if I don't know something, I'll even step out the room sometimes and say, hey, let me see if I can reach my attending physician while you're still here. So I think being honest is something that the patients will appreciate, and it makes you feel more comfortable, right? You're not like thinking about how should I kind of finesse this and anything like that. Just be honest and open, just as you would hope that the patient would be honest and open with you, right? And so, but yeah, as far as the medicine, sometimes that's just how it works, and we catch the diagnosis down the road. If I may, like a very short story, there was a gentleman. He was, around in his 60s, history of smoking, came in painless jaundice. All right, so that's classic with pancreatitis. Well, okay, so did he have pancreatitis? I don't remember, but basically we were concerned for CBD stone or malignancy. So I don't remember the fine details, but his workup, uh, was quite interesting because we couldn't find anything that was wrong with his. I guess it was pancreatitis, so it wasn't painless jaundice, but we couldn't find the cause for his pancreatitis. Even we were thinking down the lines of autoimmune, and the IgG4 levels were normal at the time. And so we finally follow up with him, 4 to 6 weeks outpatient, and we repeat the ERCP. We actually take some biopsies, and lo and behold, I mean, it's not cancerous, right? So there was no malignancy found on the biopsy, which was magnificent, but there were signs of autoimmune pancreatitis. And so, sometimes we catch the diagnosis later on down the road. And I mean, this patient was quite happy too, because, he doesn't have cancer. The treatment of it was cheap steroids, right? This guy did well on prednisone. And so, it's sometimes that's just how it unravels.
The honesty thing especially was really good advice. Another question is, how many patients do you see a day? And sort of as a follow-up, how much time do you spend doing like paperwork as opposed to seeing patients?
So whenever I'm on the clinic side, I can see up to 16 patients. That's where we agreed to cap it off. So that's something you might want to consider when you talk with your future employers, is the max load you're able to see in a day. And then on the hospital side, I mean, it can vary, but since I'm out in the community and things like that, my census are usually way less than what a hospitalist might be. It's never really up in the 15s or double digits, to say, for that manner. And then as far as admin work, I mean, that's a good chunk of the day, like 2, 3 hours of the day, I'd say. We're doing admin work, as far as actually probably more than that, because if you count like typing up your notes and everything like that. So I don't know what the statistics are, but aren't we spending like 80, 90% of our time on the computer and stuff instead of seeing patients? Is that correct, or did I just make that up?
Peter, I think it speaks to the type of job that you've chosen, which is that you can schedule your work. And so that your understanding with the folks that you work with is that you will take a certain number of patients, as opposed to different type of careers like urgent care or emergency department or so forth, that you work and you pile through as many as you can on an unscheduled basis. So different types of careers.
Sure.
And by the way, I think you call that 80% of our time documenting is probably accurate.
Yeah. Unfortunately, that's the reality of what we do. I remember listening to this TED Talk, and it was saying how this one gentleman, he was a doctor, he loved medicine, but he hated healthcare in a sense, right? All of the logistics and documenting and making sure that, there's no legal ramifications to, the care of the patient and things like that.
Peter, your office is on full electronic record. Is that true?
Yes, sir.
Okay.
Yeah.
Rohit, why don't we do one more question for our guest, and then we will turn him loose to have an evening for himself.
Finish the rest of my Chipotle.
Yeah.
All right, one last question.
Okay.
You've talked about substance abuse several times in the case studies. So how do gastroenterologists and psychiatrists collaborate on patient care?
As far as substance abuse, yeah, I personally haven't collaborated much with per se psychiatrists in a formal sense, but what I guess how I would handle substance abuse, or how I have in the community where I am, I try to look to my primary care colleagues for resources as far as alcohol cessations and things like that, because I'm honestly, I wasn't in my training, I'm not too familiar with that stuff. And so, I lack the resources and honestly the time too within my clinic to educate the patient properly on that, on the substance abuse. So sorry, I'm not too insightful in that manner, in that question.
Peter, what a wonderful presentation you've given this evening. This was just so stimulating. You've picked one of the hardest fields. Someone comes in with a bellyache, and as you said at the start of your talk, it's anywhere between the mouth and the butt, and all points in between. And the history of medicine going back over a century is the fact that abdominal pains and dilemmas can be so perplexing. So we honor you, and we are very much impressed and just very honored that you would bring your skill set to us tonight to share with us the way you think and how you chose this difficult field that can be so it can be so relieving to so many people, who are experiencing tough problems. Peter, virtual shadowing now, we have over 33,000 people that have joined us on this effort, on this, the 27th talk in the last 10 months, with over 800 universities represented worldwide, some of whom you saw tonight. So we just want you to know that typically about 5,000 people will watch this talk posted on YouTube. Each one of them, as a medical provider, will see 100,000 patients probably in their career. 100,000 times the 5,000 is 500 million. And so, Peter, tonight you will have touched 500 million lives with this wonderful talk that you gave. So we just want you to know how deeply grateful, and how this wonderful message of generosity and kindness and skill will carry on to influence generations to come. So we are very deeply grateful, and thank you so much. Rohit, I think we have a couple more slides, don't we, about the exam and all?
Yeah, just one more slide. If you could go to the next slide.
Of course.
Here is the quest-based information for the quiz. The quiz will open up a little bit after the presentation ends. Give us about 15 minutes. To take the quiz, you'll go to questbase.com, and where it says Find Assessment, you'll type in the PIN. And when it asks for a password, it's TRINH, spelled TRINH, all lowercase.
All right, I'm putting that in chat also just to make sure we have it. Well, to all 800 of you that came tonight to hear Peter's wonderful talk, we just thank you so much for coming. We're going to be here as long as you keep coming back in this very difficult year of this pandemic, which, as far as at least last night at Parkland Hospital, has no evidence of letting up at all. So we appreciate so much you coming. We will be back next week with yet another in a series of terrific talks. If it's half as good next week, Peter, as it was this week, it's going to be a terrific talk. And so on the behalf of the whole virtual shadowing team and Peter and Dr. Salazar and Dr. Morchetti, we just want to thank you so much for coming, and we wish you a good evening. Good night.
Thank you, everyone. I appreciate y'all having me.